بسم الله. نكمل في اللي كنا عم نحكي عنه. طبعا انا يعني بعتذر انه احنا مقسمين او انا مقسمه على اكثر من فيديو، لكن عشان صراحة اقدر احمل لكم اياه على الاي ليرنينج. فالان بعد ما وصلنا لهاي الخطوة وحسبنا الكوب انجل وعرفنا نعمل ديسكريبشن له، هلا خلينا نطلع على مجموعة من المعالم الاخرى اللي we are interested in. طبعا دائما الاشي الوحيد اللي بضل موجود عندي هو السنترال ساكرال فيرتيكال لاين. any other thing is يعني you could draw it, measure the angle and then delete the lines. هلا السنترال ساكرال فيرتيكال لاين هي عندي هون. هلا في عندي مصطلحين، الستيبل فيرتبرا والاند الستيبل فيرتبرا عفوا والنيوترال فيرتبرا. هلا بدنا نفرق بين هدول المعنيين. ستيبل فيرتبرا من اسمها this means انه this vertebra should be stable، وهي الفيرتبرا اللي just below الكيرف اللوست كيرف او الكودال كيرف اللي بتكون مش included في هذا الكيرف. هلا بفرجيكم كيف. هاي واحدة. تنتين عندك النيوترال فيرتبرا. النيوترال فيرتبرا او فيرتبري بالاحرى هي the vertebrae at the end of the curve، يعني من فوق ومن تحت. اللي الشرط الاساسي تبعهم انه ما يكون فيهم with no rotation whatsoever. Usually these are the same as the invertebra or the invertebrate of a curve. However, this is not a must. Sometimes they are not. وعشان هيك sometimes we do need them or we do use them. فإذا النيوترال فيرتبري صار واضح عندي هلا إنه النيوترال هم more or less similar للإند vertebrae. Sometimes they are not based on what? Based on إذا فيهم rotation الإند vertebrae ولا لا، لأنه هدول لازم ما يكون فيهم rotation بالمرة، فبالأغلب بيكونوا يا الإند vertebrae يا just above it أو مرات حتى even just below it، بس usually الإند أو above it يعني برا الكيرف. هدول النيوترال فيرتبري عشان احدد محالم الكيرف. ليتر اون هدول في السيرجيكال انترفنشن كتير مهمات عشان يحددوا من وين بقدر اثبت ومن وين بقدر اسيب التثبيت. عندي ضروريات عشان اقدر اعرف من وين بدي ابلش البوشنج عشان against الروتيشن ومن وين بقدر اوقف البوش against الروتيشن. ستيبل فيرتبرا اللي هي الفيرتبرا جاست بيلو الكودال كيرف، اذا كانوا تو كيرف تحت نص اللمبر، اذا كان ثوراسيك كيرف جاست بيلو الثوراسيك كيرف، بحيث انها تكون هاي الفيرتبرا ستيبل يعني نوت انكلودد في هذا الكيرف، ما لها علاقه في الكيرف، ما في فيها تلتينج، ما فيش فيها روتيشن، ما فيش فيها وات سو ايفر. الان لما بدنا نيجي اللي هي بيحكوها جاست بيلو هيك احفظوها، ستيبل جاست بيلو. هلا لما نيجي بدنا نحدد مثلا النيوترال فيرتبري هون. هلا اول شيء خلينا نرجع ناكد على موضوع الروتيشن. فاحنا حكينا انه الروتيشن بينحسب على الابيكال فيرتبرا. الان عندنا الابيكال فيرتبرا حددناها انها هذه الابيكال فيرتبرا. فالان لما بدي اول شيء اعمله احسب الويدث تبع هاي الفيرتبرا. سوري، خلينا نرجع كمان مرة. شيب لاين حددنا هذه هي الويدث تبعها. طبعا دير بالك ما ترسموا لاين هيك، ارسموا باراليل للإدج تبعها للأورينتيشن تبع الفيرتبرا. الآن هذا اللاين لو بدنا نيجي نحسب قديش طوله. For now I can see that this line is about 3.5 centimeter, 1.7, so it's going to be somewhere here. Now what we are doing now is the Nashmo method, which is the most commonly used method. Based on this, again I want to draw out to divide this vertebra into two halves. Be careful, it has to be two halves. Now to split it into two halves, this has to be perpendicular. No, it has to be perpendicular to the line that was drawn, and this is why I'll have to measure the angle actually. So it has to be 90 Yeah, it is. So this is the half of it. Now, again, measure the distance from the edge to the center, and then divide this area into 3 equal areas. That's going to be more or less about 4 millimeters for each area. So here I go. Sorry about that. And once again, oh, see, it was zoomed out. This is why I have variation in the measurements. So here we go again. 0.4. Let's check the measurements. Everything has been changed because of the variation in the zoom, and this is why you'll have always to be careful, because any variation would alter your measurements. So now this is 4 centimeters, the half is 2 centimeters, and then 7, and then here, this has to go up there, and again make sure that the lines are good. Just a little bit here. Again, check it again. So here we go. Everything is fine. Now this is what? This is the Nashmo method. Now we have split the apical vertebra into 3 equal areas, the half of it at the convex side. Remember, it has to be always at the convex side. Now let's zoom in further and further. And as you can see now, this is, now you'll have to be clever because you'll have to differentiate between this is the spinous process, and this is the the pedicle of the vertebra, and here is the pedicle of this vertebra. Okay, here is the pedicle of this vertebra. So if you want to measure the rotation is grade 3. So this is the first zone, the second zone, and this is the third zone. The third zone, so we are in grade 3. Grade 4 is just out the half of it. So it's quite advanced case. So again, this is grade 4. Grade 3, sorry. Let's just zoom it in for you, just to view it. So now it's clear, and if I want to align my pedicle, here it is, the pedicle. Here it is. So in this way we can identify where exactly the location of the rotation is. Okay, so maybe this is even much better. So now the apical vertebra is clear. Now let's go back. I have identified the rotation. So this is again another parameter that you'll have to include in your description of the curve. Now, once done with this, let's just get rid of these lines to make things even clearer. Now, stable vertebra and the neutral vertebra. If we're talking about this thoracic curve, so let's focus at the end vertebrae, and here let's have a closer look at the proximal end of the curve. And here what you can see is this is more or less the most tilted vertebra. Let's assume that this is the most tilted vertebra, and this is the stable vertebra, the neutral vertebra. So if this is the neutral vertebra, what we'll have to check then is this vertebra rotate or not. And as you can see, here are the pedicles. They are aligned at the edges of the curve. Here I can't actually make sure that this is the pedicle or not. I can see it clearly, but by the end of the day, first look at the end vertebrae, investigate. If there is no rotation whatsoever at these end vertebrae, you could say that these are actually the neutral vertebrae. So this is the one from the above, and now let's go for the below, and it seems like this is the most tilted vertebra. So now it's look at here, it seems to be like there is a little bit of a rotation at this vertebra. However, at this vertebra there is no rotation whatsoever. So for the neutral vertebra, I'm going to consider this as the neutral vertebra. I can say that based on my experience and the way I view the images. So here the pedicle is different from here. It looks like this pedicle is shifting, is rotating to the other side, whilst this one is not. Look at these vertebrae, it's quite clear that there is no rotation whatsoever. This one is just below the most tilted vertebra, this one is the end vertebra, this one is the neutral vertebra from below. Now, stable vertebra, here, first of all, you'll have to identify your curves. So let's go back and have a general overlook at the full image of this spine. Let's, by the way, for the stable vertebra, the rule is your central sacral vertical line has to bisect this vertebra, which means more or less split it into two halves. So have a look here. This is the central sacral vertical line that we have drawn before. This is the thoracic curve, which is quite obvious and clear that it is far away from the central sacral vertical line. Thus, we have identified it as an actual structural curve with a high degree of Cobb angle. Now, to identify structural from non-structural, you'll have to dig deep into the major and the minor one, this first and the second to appear one, and the lateral bending if you don't have enough information from the history of the patient. Now, if we have a closer look at the lumbar curve, let's zoom it in and have a look here, and I'll just zoom it in from the camera as well. Have a look here. This is the central sacral vertical line, which we are quite sure that we have drawn it correctly. Now, what I can see and you can see as well is there is a shifting, an apparent shifting in the lumbar spine from the central sacral vertical line. If it was aligned, or if there was no any type of rotation, tilting at these vertebrae, then what you will have seen is a central sacral vertical line that cross across the vertebrae, dividing them into two halves, because this is the actual alignment of the spine in the AP or PA image. Now, this is not the case here, and obviously the curve or the vertebrae are moving to the left side of the image at the lumbar region, in comparison to the thoracic region, in which the vertebrae are moving to the right side. So now here the vertebrae are moving to the left side. as you can see, moving to the left side. However, the vertebrae are still touching the what? The central sacral vertical line. So here is the puzzle. In this case scenario, if your central sacral vertical line is touching the vertebrae, however, it's not bisecting them, and the vertebrae are moving away from the central sacral vertical line into an opposite direction to the curve at the thoracic region, how will I identify this shifting? Will I call it as a compensatory curve or a curve at the lumbar region, or will I consider it as a nothing? Well, actually, it is a thing. It is a something. And you can't just ignore it and say, no, there is nothing. There is a curve at the lumbar region. This curve is minimal. So, obviously, this curve is trying to compensate for what is happening at the thoracic region. It might be a new curve that is developing at the time. For the time being, it's still a new one, but later on it will develop and become a really big compensatory, overcompensatory, or decompensatory curve. So you cannot say it is not a curve. It is a curve. What you'll have to do then is to identify its criteria or its specification criteria. What are the invertebrae of this curve, and what is the cup angle? The cup angle of this curve wouldn't be as much. If we measure it, it's going to be very minimal curve, maybe not even reaching the 20. And based on our guidelines, any curve that is less than 20 degrees measured in the cup angle is not a curve that requires orthotic intervention. So for this curve, you'll have to identify the end vertebrae, measure the curve, and see how much is the cup angle. Based on that, you will identify if you are going to intervene orthotically with this curve or not, if it was a single curve. However, in this case, it is a double curve, and obviously we'll have to intervene for the treatment of this case, depending on the angle and the laser sign and the rules that you all know. If it was below 45 but above 20 and the laser sign is still giving you some space to do the correction, and the rotation is still giving you some space for the correction, then you go for the orthotic intervention. If not, then the surgical intervention if the angle is above 45 mature, and the other specification that you should know by now. Now, in most cases, or in some scenarios, the patients do not want to go into a surgical intervention, so you will have to intervene with your orthotic intervention and just to stop the curve progression until the laser sign is 5, and then you'll have to do the observation to make sure that there is no progression in the curve after the laser is closed at 5. Now, going back to our lumbar curve, so now we have seen that this curve is moving to the left, this is moving to the right, slight, the central sacral vertical line is still touching. In general, what we say is as long as it's touching, as the cup angle is not more than 20, then this is a minor curve that does not require treatment. However, because we do have a curve at the thoracic region that requires a treatment, orthotic treatment, then in our orthosis we will include the treatment for the lumbar curve as well. Because our brace is already covering the full spine, so why not to make use of this extra addition of the